Hello everyone. Today I will be talking about the pyramidal syndrome, also known as the cortical spinal tract syndrome or the upper motor neuron syndrome. This syndrome is defined as damage of the pyramidal tract, and this is a scheme of the pyramidal tract, and it's a coronal slice, so it's as if the patient were to be looking straight at you. Now, before I jump into the syndrome, I think it is very important that I do a brief overview of the pyramidal tract, see where it originates and where it ends. So with that being said, let's get started. The pyramidal tract is going to originate in the cerebral cortex of the frontal lobe. Now, in the cerebral cortex, we are going to find nuclei as well as neurons. Now, these neurons are known as the upper motor neurons, and they are going to have fibers or axons that are going to contribute together to form white matter. Okay, and these axons are going to descend and they are going to compact in one strategic anatomical place known as the internal capsule. Let me go ahead and write that down. Okay, so as these axons pass through the internal capsule, they are going to descend through the brainstem. Now, the brainstem has three parts: the midbrain, the pons, and the medulla oblongata. So, each part of the brainstem is going to connect through nuclei of different cranial nerves. Now, these cranial nerves have a motor function. Why? Because the pyramidal tract is going to enable us to perform voluntary motor functions, okay? Such as muscle movement. Alright, so as these axons make their way down to the midbrain, they are going to connect through the nuclei of the third and fourth cranial nerve. And as they make their way down to the pons, they are going to connect through the nuclei of the fifth, sixth, and seventh cranial nerve. Okay, and as they make their way down to the medulla, they are going to connect through the nuclei of the 9th, 10th, 11th, and 12th cranial nerve. Now, as these axons reach the distal part of the medulla, there is going to be a decussation here. Now, this decussation is known as the pyramidal decussation, and what happens here is gray matter is going to anatomically distribute the pyramidal tract into two main pathways, a direct pathway and an indirect pathway. So 80% of the fibers are going to decussate over to the indirect pathway known as the lateral cortical spinal tract, while the 20% of the fibers, these are going to go directly down the anterior cortical spinal tract known as the direct pathway. So this is the left side of the brain and this is the right side of the brain. So what this decussation is telling us is that if the left side of the brain is activated, then that means that the contralateral side of the body is going to respond. Okay? Now, these tracts are going to descend and they are going to synapse to a neuron of the ventral horns of the spinal cord. Now, in the gray matter of these ventral horns, we are going to find special kinds of cells known as the Renshaw cells. Okay? Now, a quick summary of the pyramidal tract: it is going to originate in the cerebral cortex of the frontal lobe and it is going to end in the ventral horns of the spinal cord. Alright, now let's move on to the pyramidal syndrome. Okay, now the pyramidal syndrome can be caused by many diseases, okay? The pyramidal tract can be interrupted by lesions at all levels, okay? These levels include the cortical areas, the subcortical areas, white matter, brainstem, the internal capsule, and the spinal cord. Now, the cortical areas and the subcortical areas, well, these are going to be associated with heart attacks and tumors, as well as heart and hemorrhages, and also abscesses. Okay, and white matter is going to be associated with leukoariosis and multiple sclerosis. And the internal capsule is going to be associated with hemorrhages. the brainstem is going to be associated with heart attacks and hemorrhages. And the spinal cord, well, that's basically going to associate with traumatic or compressive or demyelinating spinal cord injuries. All right. Now, an amyotrophic lateral sclerosis can happen. This can be associated at any level of the pyramidal tract. Now, let's talk about the main causes of a pyramidal syndrome. The first cause is going to be a cerebrovascular disease. The second leading cause is going to be a heart attack, and the third leading cause is going to be a cerebral hemorrhage. All right, now let's move on to the clinical manifestations of the pyramidal syndrome. The first clinical manifestation is going to be a motor deficit. Let me go ahead and write that down. Okay. Now, this means that any injury that affects the frontal lobe or the brainstem, that's basically going to give us a contralateral motor deficit. Now, why contralateral? Because it occurs before the pyramidal decussation, okay? Now, if an injury were to occur after the pyramidal decussation, let's say at the level of the spinal cord, then that's basically going to give us a deficit on the same side of the lesion. All right? Now, the middle cerebral artery is basically, it's going to supply blood to the frontal lobe. So if we have an ischemic event or a hemorrhagic event of the middle cerebral artery, that's basically going to give us a contralateral pyramidal syndrome. This is going to be associated with a motor deficit, but in this case, it's specifically going to be called a hemicorporal deficit. Now, the second clinical manifestation of a pyramidal syndrome is going to be hyperreflexia. Now, what is hyperreflexia? Hyperreflexia is an increase in muscle stretch reflexes, okay? The pyramidal tract is going to inhibit the release of alpha motor neurons. So when the pyramidal tract is injured, then we are going to have a release of these alpha motor neurons, which is going to cause an increase in stretch reflexes, okay? But in acute injuries such as cerebral hemorrhages or heart attacks, then during the first few hours, these reflexes are going to be blocked due to a spinal block in which the whole circuit is going to be altered and not all reflexes are going to be elicited, okay? But after a few days or weeks, then we are going to find that hyperreflexia. That is why it is very important to explore plantar responses. So if a patient comes in with a motor deficit, then we automatically know that he or she is going to present either a left hemiparesis or a right hemiplegia along with hyperreflexia, and it is going to be associated with an extensor plantar response known as the Levinsky sign. Now that is the third clinical manifestation. Okay, so Levinsky. All right. Now, the fourth clinical manifestation is going to be hypertonia. Now, hypertonia is basically an increased muscle tone. Now, same as with the reflexes, in acute injuries during the first few hours, we are going to have hypotonia, which means a decreased muscle tone, okay? Now, after a few days or weeks, then we are going to have an increased muscle tone along with spasticity. Now, what is spasticity? Spasticity means muscle tightness. So if I try to extend my arm, then we are going to have resistance. We are going to have involuntary contractions. This is due to the stretch reflexes being exalted due to our hyperreflexic states, okay? So that is going to be the fifth clinical manifestation. Spasticity. Okay? So, example, if a patient comes in with a cerebrovascular disease, then we automatically know that there is not going to be any sign of spasticity. Why? Because this is an acute injury. However, if another patient comes in with a spastic hemiparesis, then we automatically know that there is a chronic disease involved, okay? Because that spasticity can take a lot of time to develop. It can take weeks, months, years, or even decades to develop. Alright, well, that is going to be all for the pyramidal syndrome. If you guys found this video useful, please give it a thumbs up. And on my next video, I will talk about the lower motor neuron syndrome. So if you want to stay updated, please subscribe to my channel. Thank you guys a lot for watching and stay tuned.